Thank you, Mr. Chairman, and thank you, Madam Secretary, for taking time to have a conversation with us here today. Obviously, the issues are very important. I'm concerned that some of the policies enacted out of Washington, D.C. are actually hurting the very people, individuals they were intending to help. If you could elaborate or reflect a bit on critical access hospitals, we know that that is a singular designation for a number of different approaches in various parts of the country, and obviously I represent a large number of critical access hospitals in rural Nebraska. I'm sure you're probably familiar with facilities in Kansas. The treatment of these hospitals with kind of a cookie-cutter, one-size-fits-all approach, whether it's the 96-hour rule, whether it's the physician supervision, these are very cumbersome and burdensome. I've tried to find out exactly how and why they were adopted or proposed even from HHS and CMS. Have those saved money? I mean, can you point to the effectiveness of these things? Because it seems to me that the very professionals who are trained to make healthcare decisions find Washington, D.C. meddling and standing between a patient and their provider.
Congressman, I certainly share your concern about the important nature of critical access hospitals, and as you say, coming from a state of Kansas where a vast territory is rural, and closing a hospital often means closing a community. I know how essential a hospital presence is. I think that what the administrators at CMS are trying to do is find the appropriate balance. As you know, critical access hospitals are still paid more than 100% of Medicare reimbursement. There is some evidence that the proximity of one hospital to another kind of belies the definition of critical access.
That doesn't speak to these arbitrary regulations, say physician supervision, for example, requiring a physician to be on the premises, on the same floor of the premises, when a phlebotomist might draw blood in order to be reimbursed. It seems to me that would actually drive up the cost of the delivery of care rather than, find an efficiency.
Well, again, I'd be happy to take the specifics back and try to find the evidence behind why specific recommendations were made. I can assure you that at least the staff that is looking at these situations is very concerned that patients not be jeopardized by the care and trying to not add administrative burden. But I would be happy to, if you can give me some specifics.
Absolutely.
And get the evidence back to you.
Thank you. And again, I think these are examples that I hope we can avoid of the federal government standing between a patient and his or her provider. Thank you. I yield back.
Thank you.